So I think I'll start by introducing you. But actually, I forgot to ask you a question. You're a consultant dermatologist, but you're just about to dual qualify in path.
Yeah, I'm on my way going through the path exams.
So you're in the exam stage, so I'm going to say that too.
Yeah,
and then you fill in whatever I haven't asked you.
Yeah, that's fine.
So let me do that for my Instagram. Right, so I'm introducing you today to my Instagram audience. So this is Dr. Volha Shpadaruk even. Yes, I will be better at saying that. We're just gonna refer to you as Dr. Volha.
Yes,
it's gonna be easier for everyone. So you are a consultant dermatologist here in Dubai, and you have done all your training in the UK.
Yes,
just like me. We have very similar training backgrounds.
Yes.
Yeah. So and we're about the same age. It was about the same time as well. Yeah, don't tell anyone that. We're both very young, obviously, very, very young. So we did the training roughly at the same time. You were training in, I think it was Nottingham.
In Leicester.
Leicester. And you became a consultant there.
Yes.
Right. So, but you're originally from Belarus. So all your training there, and you're a consultant dermatologist. You came to Dubai when?
2.5 years.
2.5 years ago. Okay, cool. And you're special in many ways, but you're exceptionally special here in Dubai in the UAE because you're almost certainly the only consultant dermatologist who is about to be dual accredited in pathology as well.
Fingers crossed.
Fingers crossed. She's just about to go through her exam, so we're almost there, right?
Yeah, I did my part 1.
Part 1. How many parts are there?
2.
Okay.
So
halfway.
Fingers crossed.
Fingers crossed. It's one of the hardest exams in medicine.
Yeah, it's very, very hard.
Yeah, that's why I have never done it.
It's very hard.
Try to stay away from that. It's extremely hard. I mean, I definitely have so much admiration for consultants. You become a consultant, and then you also go and do a whole other basically specialist training on top of what you have already done. So in the UAE or in Dubai, it's not recognized. So you'll never see a dermatologist here dual accredited, but you are very well recognized in the UK. So what that means, what's pathology though? Because how is that important to dermatology?
So I think it's literally like an arm and a leg of a body, right?
Okay.
Because we do biopsies, especially in cases when we don't know what's causing the problem.
Mm-hmm.
And the biopsy can give you an answer.
Right.
Sometimes the histology is very tricky, and you need to have experience to read it.
On a slide.
Sorry. To read it on the slide. And it's not only you learn as you progress, but you also learn when you send it for second opinion to your colleagues.
Yeah.
And it's absolutely normal in histology.
Yeah, absolutely.
Because even dermatopathologists specialize, some of them only melanoma.
Yes.
Some of them specialize in soft tissue tumors.
Yeah.
So, and I was really honored to have fellowship with Dr. Richard Carr in Warwick.
Yeah, legend.
Amazing, best of the best.
Yeah.
And he sends his pathology sometimes to France or Germany or US. And then even at his super high level, he still learns.
Well, yeah.
So,
absolutely.
And it's amazing specialty. And then you put it in clinical pathological correlation.
Mm-hmm.
And you see patient as a whole.
Yeah.
Not just a histology, a bit of skin or a bit of rash, and it's amazing.
Yeah, so dermatologists, obviously we diagnose rashes clinically, and then if we're not sure whether it's a skin cancer or whether it's a rash or whatever it may be, we take a small skin sample, usually 4 millimeter biopsy, and that gets sent to a lab. The lab then processes it into a slide, and we get these slides that are like pink and purple, and these are you have stains on them too, but pink and purple slides. Those slides go to a pathologist. So there are general pathologists who just do that, and who've done all their pathology training and are not dermatologists. And so the difficulty, I think, with that type of person, though there are many excellent pathologists who are not dermatologists, right, is that they never see the patient, or they don't have enough experience to know if we write lichen planus something on a biopsy, we think this is what it may be. Clinically, they can't correlate that necessarily with what it looks like. So they're kind of, they only see one half of the picture.
Yes.
Yeah. And so with someone with your skill set, you see both parts of the picture. So you see the rash and you know what it's going to look like or what it looks like. And then you also see it under a microscope. So you're able to connect the clinical with the path. And that's a skill that we're all trying to teach ourselves during dermatology training, but many of us don't have that ability to kind of visualize that. But someone with your training does, which means that when you look at a rash, you must see the slide. Yeah, so you see what's happening in the cells when you look at rash. I try to do that too, and I'm only good at it for certain rashes, but I'm not trained like you are. So to be a dermatologist with that skill set of being able to look at slides is an exceptionally powerful skill set to have. It allows you to be a much better diagnostician than most dermatologists. And so that's not something to be sniffed at, because you have a skill that most of us don't have, or very few have. And I don't think anyone in, at least Dubai, has that. Dual accreditation.
I haven't come across
anyone either. So that really sets you up in a very unique position. And you're one of the most highly skilled consultant dermatologists in probably the Middle East with this skill. So I don't
Thank
think,
you.
yeah,
Flattering.
But it's true. But when I met you and you told me you're doing the dual accreditation, I was like, oh my God, that's
Never
crazy.
stops.
The training never stops. And I was like, thank God you're here, because we need someone with your skill set to look at the slides and be able to help us understand what's actually happening in the skin from a histopathological perspective. So this is definitely a skill that you want a dermatologist to have. And so yes, that makes you exceptionally good at like medical derm, also skin cancer.
Yes, I remember when I was in training and we had these clinical pathological meetings, as you do, right?
Yeah, as you do.
And they put slide up and you think like, oh God, what's happened? This collection of cells, I have no clue what's happening. And then I thought like, I can't have this gap.
Yeah.
I have to know.
You have to know.
So then I start learning, and the more you learn about pathology, the better you become clinically.
Yes, absolutely, 100%. Absolutely.
It's just like even rare diseases, rare conditions, or even rashes which present in certain pattern histologically, then you can picture it into a special, psoriasiform or spongiotic or lichenoid. But they can look like psoriasis, but it's actually a completely different pattern. So it's completely different disease.
Yes.
And it actually sets your mind in a different way, how to look at the patient and correlate. I noticed that I became a lot better clinically because I learned histology. Even for just become better clinician, to learn histology is just more than enough.
Yeah, well, yes. I mean, the only histology I really am good at looking at is basal cell carcinomas because of my Mohs training. Yeah. So I'm good at looking those. So I can see a slide, I can see a BC and think this is what it's going to look like under the microscope, because I have to know for the
But
Mohs
tell us
surgery.
more about Mohs actually.
Okay.
Because Mohs surgery is a separate year after CCT.
Yes.
Of additional training, which you have to apply for and go through the competition and get the job and train with the people who allowed to train you.
Yeah,
it's not like just any place or any.
Just like with you, it's just not.
It's a competitive
thing,
and it's completely different skill which only a number of people in UK have.
Yeah.
So. I did refer you a few patients for the head and neck and stuff.
Yeah.
So tell us about Mohs, what that is, because not everybody knows about it.
So Mohs is named after Dr. Mohs, who's a guy from like Wisconsin or something. Old, he's not alive anymore. And he created this concept of looking at what's called frozen sections for skin cancer, so you get an immediate answer. So with skin biopsies or samples, we can either put them through a frozen section where you get a result within like 20 minutes. You have a slide really fast, and that can be done immediately, or through paraffin, where it takes about 12 hours at least, and then another 24 hours or so to make the slides, right? So the idea was to use the frozen section to be able to diagnose whether or not the basal cell carcinoma that I've just removed, or someone's removed on the head and neck, has been completely cut out. Because the worst thing ever with BCCs, because they're generally occurring on the head and neck, is to remove a BCC, then do a beautiful repair, and then the results come back and it says that it's still there. That's terrible.
Terrible, yes.
And then you have to go back and fix it. So removing basal cell carcinomas with an ill-defined margin in certain cosmetic areas of the face really needs to have Mohs surgery, because otherwise you risk having a poor aesthetic outcome, but also not removing the whole thing. The risk of recurrence of the basal cell carcinoma goes down tremendously when you use Mohs surgery, because we know we got every last cell. The way that the specimen's cut is different. So everything about that is different. As a Mohs surgeon, we have to know how to read slides. We have to read our own slides. I train in Newcastle with some of the best Mohs surgeons in a large part of the world. So James Langtree, Tom Oliphant. So I had that. I went there because the trainers were so exceptional, just like you went because the trainers were, the consultants were exceptional and they know their stuff. So yeah, I spent a year doing that. It was the greatest year of my training. So all I did was, roll myself into the hospital at 7 a.m. in my scrubs and roll back. And it was really fun because skin cancer removal, okay, not fun for the patient, really fun for us because it's so creative. And you also need to learn the path side. So there's a lot of stuff to that. And so now I'm very good at removing anything from the head and neck, pretty much. It's a good specialty.
So it combines not only clinical diagnosis with dermatoscope, the Mohs surgery. You need to diagnose it clinically. Then you do a biopsy to confirm the type of basal cell, which are many types. Then you actually do surgery, which is kind of a plastic surgery skill. Then you do a bit of histology on that specimen.
Look at the slide,
Yeah, and then you close the defect.
It's all in one day.
All in one day. Your patient might be quite a few hours.
Yeah, it might take a few hours.
The beauty of dermatology, it combines and sort of interconnects with almost every specialty.
Yeah, totally, yeah.
It's not only skin. It's literally like surgery. Cancer oncology, right?
Yes.
Pediatrics.
Yep.
Oral medicine.
Yep.
Hair loss,
gynecology,
genital disease,
disease, gynae.
So it's a rheumatology, connective disease.
Did you say endocrinology?
Endocrine, So because we refer patients PCOS and all that kind of stuff.
Psychology.
Now it's emerging, isn't it? Before we didn't recognize the psychological impact, but it's huge. It's possibly the main problem people have is psychological impact
of their skin disease on their mental health.
Mental health,
Massive, yes.
So possibly out of all other specialties, possibly dermatology is the top.
Yeah, totally. But we're a little biased.
No, I would say, look, I wanted to ask you about actually body dysmorphic disorder, It's like literally not long ago we start recognizing this.
Yes.
Right?
Yeah.
So I see a lot of patients who come and they have procedure, after injection, after surgery, after something done, but they're never satisfied. They still never. And then you have to be the one, not a very pleasant one, to tell them, unfortunately, you can't do anything for them.
Yeah, you're done now.
Until you see a psychologist and work through it. And they say, like, oh, other doctors did it before. Why can't you?
Yeah, exactly.
I wouldn't be able to do it because you have another condition which we need to manage before we address other skin concerns you might have.
Yeah, absolutely.
How do you deal with them? What is your approach?
Dermatopsychology. Well, I think the most common thing I see is like skin dysmorphia. So I don't get a lot of body because we don't deal with body, implants and things like that. So I call it skin dysmorphia. I don't know if that's a real term, but that's what I call it. Is it a real term? Have you ever heard skin dysmorphia?
I haven't heard, but you can call it.
Maybe I've invented something new.
You invent for your second book.
For my next book. It's going to be called skin dysmorphia syndrome or whatever. But to me, it's like when patients come in and they have, and you probably experience this too, they have like maybe one pimple or they show a photograph of when they had a pimple, but their skin's perfectly clear. And they're like, I'm really suffering from acne. I got all these pimples. They show you a picture of one tiny spot and it's like, well, that's not really acne. Or they see things on their skin that aren't really there. Like, oh, I have such bad acne scar. And you're like, I don't really see it.
Where is my dermatoscope?
Yeah, where's my dermatoscope to look for the acne scarring? Or someone who, I have a lot of patients who feel like they have thinning hair, but it's very much cultural as well. But that they have great hair and I don't see any thinning, but they think they have thinning hair. So those are the kind of things I see a lot of. And it's so difficult to then, how do we treat them? Do we treat them for acne? Do we treat them for hair loss? Do we perpetuate that skin dysmorphia issue? Or do we say, no, you don't need treatment, adios? Like, I never know what the best way. It took me, I had one specific patient who had this he was a male patient, he had it with his hair and also with his skin, very young, 20 something when he started seeing me. It took me 4 years to get him over his skin dysmorphia. And I treated his skin.
It's a journey.
It's a journey. And 4 years later, I finally saw him for the last time. He was leaving the UK anyway. And he was like, thank you so much. Because 4 years ago, he came to my clinic crying, beautiful skin, beautiful hair. His skin and hair are no different than they were the first day I met him. But his perception of it has changed.
Completely, yeah.
And I did treat him for stuff. And it made him feel better. And in the end, we got to the end. He never saw a psychologist or anything. He probably maybe I should have sent him to someone But
it's a journey.
It's a journey.
I think it's a I would say it's a disease on its own, psychological disease.
Yeah.
But we're very shy to speak about it.
Yeah.
Because stigma attached in certain, countries especially. So I closely work with the psychologist.
Here in Dubai?
Yeah.
Okay.
I can share later.
Yeah,
details.
share later.
And she does EMDR. When people don't want to talk,
Okay.
they don't want to talk, especially men.
Yeah.
They don't want to share things. They have this procedure EMDR when there is a machine which produces the impulses, depends on the setting. And it kind of resets the brain to file the concerns they have unfiled.
Electroshock therapy.
No, it's not. It's very nice and pleasant.
Okay.
It's not kind of disruptive or anything. But it requires a number of sessions, depends on the depth of the problem. And I had actually recently 2 patients. One of them had their hair loss and another one had picking disorder.
All right.
So we work together.
Yeah. Yeah.
So we worked with this psychologist very closely, and they had EMDR, they had cognitive behavioral therapy, and actually they acknowledge now they had the problem, right? And they're getting over it. Now they're managing it better. So, and the first step is usually to get the person to accept the help.
Yes. Well, yeah.
And then work along. And then look back how much how far they come from the starting point to now, and how much they improved. It's a huge encouragement for them. Yeah. So I lost a few patients because I offered them they need help. They went to somebody else, but
did what they wanted.
2 years later, even here in Dubai, they would come back.
Yeah.
They've gone, rounds and rounds.
Rounds and rounds. Yeah.
This was my another question to you actually. About doctor shopping,
dermatologist shopping
leads from this kind of discussion.
Yeah.
So they go doctor shopping. They see 20. I had a patient, 26 doctors.
Doctors, not dermatologists.
Dermatologists, GPs who are saying they're dermatologists.
Oh yeah, aesthetic doctors.
Aesthetic doctors, plastic surgeons. So 26. Then she comes back and said, "Please, just do something."
Yeah.
And you have to undo not only the problem that she has, to fix it, undo the damage those opinions have done. And it's actually very tricky.
Oh my God, it's so difficult. Yeah, I have that all the time.
So I really find this is the biggest challenge, not to diagnose a patient, not to manage the patient, not the actually skin
that's
condition.
The easy part.
I find it difficult to actually undo the damage of other opinions.
Yeah. Oh my God, it happens to me every day. It probably happens to you every day, especially here. I've never seen it quite as bad as it is in Dubai. When in England, we don't really have this problem because people don't doctor shop so much. But here you have a dermatologist on every street corner. So you can pretty much go to whoever you want on Jumeirah Beach Road, Al-Wasl Road, go through all of them. And most of them aren't consultant dermatologists. Well, the majority are not. They're not properly trained dermatologists. Whatever. So, and I've, you can look them up on DHA website and see what kind of training they've had. But yeah, that really causes massive problems. I'm not going to give examples. Even I think yesterday I had like 3 people who had doctor shopped and I had to like rewind what they were told.
Yes.
In order to be able to take their treatment forward.
Yes.
Because like, oh no, the other doctor said this, the other doctor said this. I'm like, oh God, here we go. But yeah, it is annoying. It is annoying. I wish that if you're going to pretend to be a dermatologist, just have some knowledge.
Yeah. Sometimes I get referrals from Al-Wasl Road from aesthetic doctors who say, this is my limit. Now go and see a dermatologist.
At least they know their limit. That's exceptional.
That's the beauty. When I need their help with aesthetic bit, I will say this is the good one.
Yeah.
They know what they're doing. They know their limits.
Yeah, they're not crazy. Yes. Maybe they are with some filler, but yeah, they're not crazy.
Yeah, but you see, this is the kind of a treasure to find someone colleague. Like that. So to refer to.
It's incredibly hard to find consultant dermatologist colleagues in Dubai because there's so much competition.
Competition is crazy.
Everyone's trying to compete, not competition for patients so much as everyone's just trying to compete with each other. And that makes
it... what? The question is what for you competing for?
I know, what are you competing for? There's so many patients here that there's so many dermatology patients all over the world that we don't need to compete with each other. We can help each other and work together to do the best thing for the patient.
Yeah.
So it's really hard to find someone. I mean, until I haven't had any dermatologists to refer patients to. So
yeah, important to mention to people that multidisciplinary approach is absolutely gold standard and norm in Europe.
Yeah, to ask other doctors' opinions.
Yes, here sometimes people see it's your weakness.
It's a weakness. Mm-hmm.
So for example, if I say I'm going to have multidisciplinary kind of meeting with my colleague, so, she doesn't know anything. We're gonna go somewhere else to ask. But seriously, and I to be honest, in the UK, multidisciplinary meeting for skin cancer is a must.
It's a must. Yeah, it's required.
It's a gold standard and it's a government level requirement.
Yeah.
Yes, here, if you say, I'm going to consult with oncology doctor, because I also have colleague oncologist who does radiotherapy, plastic surgeon, who we can sit together and actually discuss. Instead of being happy that actually so many doctors look at different angles, find the best solution for this particular case, because every patient is an individual, right?
Yeah.
They said, she doesn't know anything. I'm going to go to somebody. And then somebody said, I know it all. I know what you need to have done. Chop this off, cut this off.
These lasers.
Have whole body MRI.
And a bunch of skincare from L'Oreal.
Yeah. So
magic.
That's, yes. And you see the education to say it's not the weakness, it's the strength to involve other specialties who actually need to be involved.
And also to know our own limits. Like, I'm not a dermatopathologist. I'm not an expert in that area. So, and you're not going to do Mohs surgery.
No, definitely. I know people who can do it, so I refer.
Yeah, exactly. I'm going to refer patients. You do a lot more medical dermatology than I do, so I refer more like high-level, complicated cases to you where they need, mixtures of drugs and medications to get them better. So yeah, I know where my limits are.
Yes.
And I try to make sure the patient understands that. But I find that like the more kind of expat population of patients here do kind of understand that, but I think this might be also partially like it's not culturally related, where certain cultures expect you to know everything, and if you don't know everything, that's a sign of your weakness, kind of thing.
Yeah, they see it that way, but you see, no matter how much, like I said, I identify the gap, I learn. I learn. But there are so many gaps which you just can't address because of the breadth of the specialty.
Yeah.
And every year, new hundreds biologics coming out in every specialty: rheumatology, dermatology, gastro, and you simply cannot know everything.
No.
And for example, I wouldn't know how this can interact with that biologic prescribed by gastro. So I need to ask if we're okay to give this medication in that gastro condition. Yeah. Absolutely normal.
That's normal.
Yes.
And that's why I've always loved working in
safe.
Hospitals. I mean, obviously I've worked in hospitals here for many years, and you have too.
Yeah.
So hospital medicine was more, we were more able to do that. But when you work in your own private setting or your own with non-related doctors or whatever, then, especially if it's a competitive type of clinical environment, then you're never going to get a second opinion from anyone. So they just don't want to, either they don't want to give it to you, or they think you're stupid because you don't know something. And so I think in the UK, like I still WhatsApp different doctors with different specialities in the UK, dermatologists as well as non-dermatologists, to ask them questions because I have no one to ask here.
Yeah.
So I'm like, hey guys, what do you think of this? That's normal. That's normal.
It's safe, it's normal, it's practiced worldwide, and it's considered gold standard level of practice.
And doctors, we don't know everything. Like we still have to, like you said, we learn every day. I learn all the time, constantly learning. I don't need to read a textbook because my patients teach me everything I need to know.
You see, what I wanted to talk to you as well.
Yeah.
Textbook, it was written years ago.
Yes, exactly. Listening.
So nowadays doctors read journals.
ChatGPT? Oh no, journals.
Journals. ChatGPT. Actually, about the ChatGPT, when I was writing my master's in exosomes, my aesthetic research, ChatGPT was actually creating the references.
Oh, God.
When you actually take the reference and put in PubMed, it doesn't exist. So that's the problem ChatGPT and AI has. They can make it up.
Yeah, I haven't come across that, but I've only used it like once.
Yeah, it does. It does happen. It's known phenomenon.
Oh my God.
By the way.
I mean,
so if you use that, check the reference for actually existing.
It exists.
Yeah,
Oh my
but they
God.
don't.
Yeah, I'm not. I mean, you don't use ChatGPT for research. I go to PubMed straight.
Yeah, you don't, but you can sometimes give them a task, what
Yeah.
kind of, general task, and then you start framing and everything.
Mm-hmm.
And then they come up, I said, where's the reference from, and the ChatGPT just creates a reference. When you actually take the reference to put in the PubMed, it doesn't exist.
That's just wild.
So it's apparently this phenomenon, AI can make it. I can't remember, it's called dreaming or...
Dreaming, dreaming.
Or something, I don't know what is it called.
ChatGPT is dreaming.
Yeah. So I don't know how it's called, but it's something kind of phenomenon. Yeah, it exists.
Yeah.
It's known.
But wait, you did a master. I think I knew this, but you did your master because you did a master's in aesthetics.
Yeah.
Which one did you do again? Because I did one too.
I did with Ulster University.
Oh, okay, yeah. I did.
And Birmingham Dental School was our base where we had clinics and cadaveric course and all that kind of.
You did cadavers for aesthetics?
Yes.
Oh, I didn't do that in mine. Okay.
We did year 1 and we did year 2. We had exams on cadavers. We had dissection. We had clinical part. We had exams on the patients.
Oh my goodness.
It was hands-on. That's the reason I picked this.
This one. Yeah.
So it was amazing course, and I really enjoyed, but it was very heavy on writing. We had to write a lot of cases. We had 3 models every year, write from A to Z their plan, what problem they might have, what aging stage, and and then come up with a plan, and then body dysmorphia questionnaires, all these kind of questionnaires to identify the patient, maybe they're asking something wrong. And then we had live kind of cases on Zoom. Then we had real patients in the dental school where we had to assess and inject and how to hold the hand, how to put the needle, which angle. That was amazing. And then obviously masters came and we had extensive training in research, how to design methodology, which is very boring, but at the same time, very, to do research is very, very difficult.
It's super hard. Yeah.
So therefore...
It's a full-time job. Yeah.
Yeah. So I did on exosomes and it was dreadful because there is no much of...
There's not a lot about exosomes.
But I managed to do kind of a systematic review of available half-hearted studies. So about 19 studies I managed to find.
Oh, that's more than I found.
So I even...
I need to read this paper of yours.
Yeah, I yet to publish.
Oh, you've not published it? Oh.
I presented though in March in Monaco in a World Congress. So it was quite a successful meeting and had lots of people to attend the meeting. So it was good. I need to publish. I really need.
But exosomes, we're referring to the salmon sperm that's coming from Korea. That's what we're talking about, right?
No.
That's polynucleotides.
Polynucleotides.
Sorry, my bad. So what are exosomes exactly? Because I get this question all the time.
Yeah, exosomes is basically small little vesicles, like tiny nanovesicles, which contain...
Like little balls.
Yeah, contain DNA, RNA, or anything human puts in it. So we can have a cell, any cell produce them, any cell, actually. So this cell can be cancerous cell. So if you take cancerous exosomes, there will obviously be not a good exosomes.
So they're fragments of DNA of the cell you're taking it from, or like pieces?
It's like excretion vesicles. In the past, in 1940s, they were thinking it's just the rubbish excreted in the little balls of the cell.
Oh.
Like a little vesicles.
Okay.
Yeah. So they initially thought it contains rubbish.
Yeah.
And they excrete. But this vesicle go to another cell and give signal and pass the information, a message.
Right.
So, for example, the cancer cell will produce bad exosomes with the bad information.
Okay.
Make other cells cancerous or diseased.
But not necessarily skin, everything.
Any
cell.
Because oncology using exosomes, orthopedics using exosomes, like a tissue viability using exosomes, like literally any specialty. Now even there are some studies coming up in eczema on exosomes.
Oh, right.
I did for aesthetic purposes for aging.
Yeah.
But obviously when I was reading, I was coming across all these other studies.
So it's not a new concept, because a lot of people think it's a new concept.
Well, it became new only a few years ago when people said, it does rejuvenation. We can slap it on and it doesn't have any side effects.
As a cream or as an injected thing? It's like an injected.
No, you can't inject it because it's not FDA approved for injections at all.
But I'm pretty sure people are injecting it.
This is wrong. They should not be.
Oh, right. Okay.
There are case reports coming out. I think I came across 2. It creates granulomas.
Okay, so similar to
So you cannot inject. The reason being for exosomes at the moment, only a few brands which are kind of well researched.
Right.
The rest, which are appearing, like mushrooms after the rain.
Yes,
so
I get
they
you.
are not well researched. They were not studied. They were not published. They are. I don't know what they are.
You mean the ones that everyone advertises on Jumeirah Beach Road?
Yeah.
Those exosomes.
Yeah. So
what's in those? No idea.
I don't know.
They're probably not exosomes. They're probably hyaluronic acid.
So those vesicles, they excreted by any cell, but we can modify the cell to make the content of the exosome the way we want, or we can modify exosome itself to pack with something. So that's why the synthetic coming exosomes.
Okay.
So very common from the fat cells.
Right.
Right? The exosome from the fat cells.
So why would you want to inject that into yourself?
So the fat cells exosomes, the most researched, the ones which started all the concept.
Oh, right. Interesting.
Yeah? So, and these exosomes, they need to be purified. In order to purify exosomes, because they're so small, you need to use number of methods.
Okay.
Centrifuge, then the bloating, and then all this kind of ELISAs and all this.
Yeah.
Because this process is so expensive, there is no way exosome can be cheap. First of all, if it's cheap exosomes, run away because of the purification. Then the problem we have is concentration. We don't have unifying concentration, which is safe.
Okay.
So some people use 2 billion, some people use 5, most researchers 5. Some people use double. And we found some papers that when there's a double of exosomes, they not necessarily give you benefit. They can give you side effects.
Okay.
So problem we have, number one, where they derived from.
Yeah.
How they purified.
Yeah.
What the concentration we should use.
Yeah.
Right?
So we don't know anything.
We don't know anything.
For skin aging specifically.
So,
but right now, clinically, they're being used in other specialties as injections or creams or what?
So there are studies for the leg ulcers to use it as injections.
Okay.
But you have an ulcer, it's already granulating, scarring.
Yeah.
You can inject, right?
Yeah.
Kind of, for the trial purposes.
Right.
And see what comes out. So I suspect in trials you can inject. But in real life, it's not licensed. It's not safe.
But it's being done. I'm just checking. I'm just Googling it for Dubai, like exosomes. Oh, this one is Barbara Sturm, our favorite orthopedic surgeon, who's not an orthopedic surgeon. She has an exomatic face serum.
So that's the question, where they're coming from. There are only a few, I won't say the names, but there are a few only published and researched.
For skin aging or for?
For skin aging. But they also can be used for hair, for ulcers, for eczema.
Here, there's the Inky List Exosome Hydroglow Complex. So this is from lookfantastic.ae.
But I have to mention the exosomes, another problem with exosome stability.
Right.
So I wonder how they make these creams stable. Because the exosomes, they either can be dried out, lyophilized,
right,
or they frozen, right, in minus temperature.
Okay.
Then they have to be stored either in a fridge or diluted and be used this moment.
So in a cream, it's kind of...
I wonder how stable are they?
Well, it gives you radiant looking skin, apparently. And it's infused with balancing actives. I don't know these words. Powered by plant-derived exosome technology, the first of its kind serum indulges the skin with a visible smoothing effect while improving the look of texture and tone. And this is the ingredient list. What is exosome called in an ingredient list?
I don't know what they call it. Because the exosomes.
There's nothing interesting in that ingredient list that makes me think exosome or something new.
No, it's water in the first place.
Yeah, water. It's water.
So my question, from my research, I don't know how they make it stable in the cream for that long, because cream has 1 to 2 year shelf life. So how this exosomes case becomes stable?
So many.
There's
zero exosome, Medicube zero exosome shot 1 day shot, 89 dirhams. And it gives concentrations of all this stuff. I've not come across this actually. I wasn't looking.
So I can tell you the creams are not stable.
Okay, so
I don't know what is in them.
Ditch the creams. I can't believe there's so many.
So the most important, you need to have the practitioner who actually knows where they come from
Yeah.
the exosomes. They know, they have all the paperwork, concentration, purification. And also, in UK, we're not allowed to use human-derived exosomes.
That makes sense.
We only allowed plant, bovine, or a red deer umbilical cord. Here you have all sorts, from placenta, from fat cells, from bone marrow, from any kind of...
But these can't be licensed products. I mean, or
They're not
registered products.
They're not licensed as, medical. They're licensed as a cosmetic. Cosmetic can be put on the skin.
Yeah.
But people take it beyond. They inject.
Yeah, so you can, for only 5,000 AED, you can get a treatment of pure stem cell derived exosomes injected into your skin. And here you can get 4 PRP sessions with metacell MCT plasma exosomes. So they basically, PRP, they must be injecting it into the skin.
Well, PRP, yes, you can inject PRP, isn't it? But at that conference in Monaco, there was a guy professor from USA. He did research in PRP, infertility, and ovaries rejuvenation.
Right.
After 40, 45, for example, if lady perimenopausal, menopausal, they inject PRP in ovaries to start producing.
Into the ovaries?
Yes.
Nice.
It's normal. It's normal. Yeah, PRP.
Good. PRP is done for ortho
PRP.
ovaries, apparently. Okay.
So, and apparently it increased fertility. Ovaries start producing eggs.
Yeah.
And hormones go back to normal. So he had it in the lab done, and apparently the PRP contains that person exosomes, which on this nano level rejuvenate their own ovaries.
Well, that's going to be interesting if it comes into proper use. It's not. I imagine it's not been used.
No, it is used.
Oh, it's used
in IVF centers. They do intrauterine PRP. They do inject ovaries. Yes, it's used in gynecology.
So there are some interesting medical uses of exosome.
Yes.
But then you did yours on skin aging. So what did you find?
So basically, it has to be applied topically only.
It can't be injected.
No, it can't be injected. It's not licensed by FDA at all.
This offer of 4,000 dirhams for one session on face, neck, and hair of exosomes.
You can do microneedling and microneedling or laser, which will create little channels.
Okay, so do a CO2 laser and then apply it to the skin?
And then put it on the top.
Okay, what's it meant to do then?
It apparently, exosome cannot go through the skin on its own. It needs to have a channel.
Right, yeah.
When that vesicle goes into the skin, it becomes anti-inflammatory.
Right.
It helps with the collagen.
Okay.
It does not really help with the healing faster.
Okay.
Everybody says, after surgery or this or that, it will heal faster. No, it doesn't.
Okay.
There's no evidence for that.
Does not.
It's actually exactly the same as...
Vaseline?
Your favorite Vaseline? Yeah. But it does actually help with pores.
Okay.
Pore size. It reduces a little bit. And pigmentation.
Pigmentation. I want to see that happening.
Yes.
Okay. And those are robust trials or not just...
No, there are no robust trials.
There are no... Okay, you said that at the beginning.
It's a maximum 60 people, randomized controlled trials, half face.
And half face studies.
But the problem with those half face, they do one, they treat, one they don't. But exosomes have tendency to sort of trickle and diffuse.
Yeah, diffuse, absolutely.
Right? So we need to have a person which didn't have any and a person which had something rather than half a face, because this might improve as well by diffusion.
It's a cheap way to do a study, though, if you use one person's face. But no, I mean, I think for a lot of things, the half face study doesn't really say much. So the evidence is poor. There were 19 studies that used, from your data, 19 studies that used or looked at exosome use either topically or mesode.
No, none of them injected. None of these studies.
All cream.
None of these studies were injectables at all.
But some with laser and some with PRP.
Yes, majority of the exosomes best work with microneedling. Downtime is less than laser.
Right. Well, I imagine CO2 laser. But it has to be specific exosomes. It can't be these. Because you said they're not licensed for the use in skin.
No, there are only a few brands which I'm not going to advocate.
No.
But there are only
why
a few
don't you
brands.
advocate it? Why don't you want to? Why? I mean, I don't need you to name. We don't want to name brands, but why would you not advocate?
I don't advertise any brands.
No, either. Okay, fine.
Yeah,
I understand that.
I don't name any.
No brands.
Any brands. If somebody wants to know, they have to go and see the doctor who is specializing in exosomes in that.
So there are a couple brands that can be used with like the PRP, the needling.
Yeah.
And do they do anything that they're meant to do?
Yes, they actually have quite a good, robust. Some of the exosomes have over 15 years of experience.
Right.
And some of them had reasonably, for aesthetic medicine, reasonably reliable studies.
Okay.
You know, in aesthetic medicine, you're not going to have RCTs like for psoriasis. And, you will have a reasonably weak to moderate level of evidence.
Yeah, they're not ever very good.
But it's still good to have it.
Yeah. Okay.
But I personally, reading all the exosomes and everything, I personally think this is the future of aesthetics. And this is future of medicine. We're looking at the DNA level, medicine very soon.
Mm-hmm. Yeah.
All this will come because look, biologics.
Yeah.
We're looking at interleukins and this anti-inflammatory.
Like 20 years to get there.
Well, exosomes only started a few years ago being famous. Give it another 20, 25 years. I think we possibly will treat cancer with those.
Oh, interesting. Oh no, that'd be great. What our patients are going to think about now is, should I get this treatment? But if you don't know what type of exosome you're getting.
So if you don't know where it's coming from and your practitioner has no papers.
Papers as in published papers?
No, papers to be approved here.
Oh, wait, hold on. So this needs a whole new, I would have to get an approval from?
So the company who sells you exosomes have to have approval from the Dubai government, whatever channels they do it, that it's allowed to be used in UAE.
Okay.
Right? Because not every exosome here is approved, whatever comes from neighboring countries. So,
not to name any names, but neighboring countries.
So there are only a few brands I'm aware of personally when I go to all these meetings.
And they're available here?
Yes, they are available here.
Right. And are they really expensive?
The exosomes, properly done, they are expensive.
Like how much are we talking?
So you're talking between 1,000 to 3,000, depends on the exosome type.
What?
A bottle.
Currency are we talking?
Dirhams.
Oh, no, that sounds bad. Yeah. I mean, people spend 12,000 on a
So if
facial.
you have an exosome 1,000, then run away.
If it's 1,000 dirhams, it's too cheap.
Yeah.
But these clinics never tell you the cost of the actual product because everything's marked up so much. So you don't know what the cost of the syringe is, or what is it? Syringe, a bottle, a vial.
Bottle, vial.
Yeah, no one tells you what the cost of the vial is.
And the vial has to be open in front of you. It shouldn't.
Oh yeah, because it needs to be fresh, doesn't it?
It needs to be fresh. It shouldn't be shared between the patients.
Oh, so I always say to patients, like, if you're walking into an aesthetic thing and the syringe is already lying there,
run away.
Run away, because God knows what the hell's in that syringe. Because there's lots of unlicensed, unregistered products running around.
You have to be a syringe filler. Toxin has to be open in front of you. I show my patients. I said, look, this is the expiry date.
Yeah, I do that too.
This is the box I'm opening, and they're like, oh, okay, why are you showing me that?
Because you have, I do that too. I'm like, this is the Juvederm. This is your one. It's so, and this is the code that we're going to stick on the consent form so we know which batch it came from. Yeah, I don't think a lot of people do that here. So, and I also do with Botox. I make sure they see the bottle and that it's actual Botox, blah, blah, blah.
Yeah,
that's what I do.
And dilute in front of them.
Yeah, I do. I often dilute in front of the patient. So they're like, is that what's going in my face with that giant needle? I'm like, no.
Relax, this is just dilution.
It's a dilution needle.
Actually, I wanted to mention, have you seen the Instagram people drawing from the toxin, this little 0.3, 0.5 BD syringes?
Yeah.
They go through the thick rubber with that tiny needle, and then they somehow manage to inject it back in a patient. So that needle is possibly like...
And it's also blunt.
Blunt, yeah.
That's going to hurt so
not
much
sterile
more. Not
blunt.
sterile, blunt.
So when I look at that, I was like, okay.
That's terrible practice. Oh my God. Yeah, so if you see a doctor drawing up with a tiny little needle that then sticks right into your face, that's probably not the one you want.
Yeah.
So
I mean, if you use that needle, which doesn't have detachable, you have to open. You have to draw.
Yeah, you can open the Botox bottle.
Yeah.
I don't generally do that. But so with these, so the exosome thing is interesting. So if a patient or someone watching this is like, I definitely want to try this exosome thing, sounds miraculous. But just to clarify, what is it meant to do to anti-aging?
Collagen and elastin stimulation.
Okay, so that's just like anything stuck in the skin, though.
Potentially microneedling itself promotes.
Yeah.
Exosomes are anti-inflammatory.
Yeah.
And I think the use in orthopedics and use in gynecology and use in a wound, it's actually will have a lot more research, proper RTCs coming. From that direction, but not aesthetics.
So do you use exosomes in your practice?
Yes, I use just 2 brands.
Okay.
And I use microneedling.
And you microneedle it.
Yeah, I mostly use it for wrinkles and, for example, after freshly treated with, Accutane, isotretinoin, Orotan, whatever. They have these pink scars, kind of.
The Mickey scars, yeah.
Beautiful as well.
Yeah. And so you microneedle, as in you don't inject it into skin, but you...
I microneedle.
But how, like with a roller?
No, the Dermapen.
The Dermapen, okay. See,
Not to name the brands.
Not to name a pen. But so it's like basically, because I always get confused when people talk about this. So you mean the stamp thing, or you're actually using a syringe? I know I'm asking a stupid question.
Not stamp, you put it topically.
Topically, and then you
created channels and you put it topically.
You first create the channels with the rolly thing?
Yeah.
And then, okay, if that's what because I'm when people say needling my face, I'm like, okay, well, what are we talking about?
No, we're not talking about home rollers.
Oh, right,
we're not talking about any stamping devices.
Yes.
We're talking about proper medical grade derma pens or whatever pens they're called.
Yeah.
Because they are sterile tips, only used
and
once
the
for
depth,
that.
The length.
And the depth is special depth because you have to be more than a millimeter.
Yeah, absolutely. But you're going to draw blood then.
Yes, you have pinpoint.
You have pinpoint, the blood will be there. So, I mean, I always think at least 2 millimeters is required if you're going to do...
Depends how patient tolerates because they're coming for a number of sessions. You obviously work with the person and depends on the location.
Yeah, because I think forehead, you don't want to go...
Painful.
It's very painful. Yeah. And certain areas, all right, that's super interesting. So, you wrote the paper on this, so I have to...
Hopefully I will publish one day.
Can you send it to me pre-published? I want to have a read of it because you basically done a systematic review on what is currently out there.
Yeah.
So that's super helpful and super useful, and we know that Dr. Volha is going to do it properly. You're not going to cut corners.
I was supervised by the university. You have to do it properly.
Yeah, no way can you not do it properly.
Yeah.
So you should definitely publish that. Or also just send me a copy, please. But no, that's interesting. So there's only a couple exosome brands that are available. It's pretty damn expensive.
And it has to be done properly. They have to be stored properly.
One vial per patient.
And I always ask them what their concentration and how they purified.
Right, but the respectable brand
will know all of this. They will give you all of that.
The information.
They will give you all, and the rep will come and know this. If they say, I'm not sure, or other clinics injecting as well, thank you very much.
Because there must be a ton of fake ones or not legit.
Yes.
So when you go to a random clinic you find on Google, you don't have a clue what you're walking into.
No.
So you'd be paying thousands of dirhams for exosomes, but they're not exosomes.
May not be, no.
They probably
maybe just growth factors or something. What they're putting in the cream, maybe just growth factors or something. I don't know what they're putting in the cream because exosomes unstable.
Yeah, you can't put it in a cream. So all those expensive creams are now being sold with exosome on the front of the bottle. That's all a scam, basically.
I suspect.
Dr. Volha, you're much more diplomatic than me. I'm just like, no, it's all a scam.
Well, we don't know for sure.
It might be.
But from my understanding, my knowledge, I question how they can be stable for that long.
Yeah.
So I don't know, maybe they have unique technology, which...
You would know about that. If they nanoparticle technology. I mean, you would know if they had nanoparticle technology or something funky.
It's very expensive. If they do, the cream should be very, very, very
expensive. That's a problem. They are very expensive.
So
now you have no idea what you're doing.
Exactly.
So I would recommend staying away from any creams currently
that have exosome.
Yeah, at the moment, or maybe for the next few years.
Away from creams.
Don't buy the very expensive exosome-laced creams because they're probably not exosome-laced at all and will do nothing more than a moisturizer.
Yeah.
So stay away from those. But if you're going to have injectable exosomes for anti-aging or whatever it is, then you want to make sure that you have the right stuff. And if you ask 99% of clinics and you call them up and say, what brand exosome are you using? And is there data that you can send me about the stability?
Yes.
I guarantee you they'll be like, we don't know what you're talking about.
Yeah. You have right to request information about the exosome you want to use.
Yeah.
And the practitioner should be able to provide it or papers.
Yeah.
So if they can't, I mean, this is questionable.
Because that means the person who gave them their exosome, the person who distributes it, they don't have that data generally. But
they didn't check.
They didn't check. But there's a lot of but dodgy fillers, different types of Botox that we don't know anything about, exosomes now as well. So I think I always say, if it sounds too cheap to be true, if you're getting Botox for 600 dirhams for your whole face or your areas, I'm always like, that's definitely not possibly anything good. But if it's way too expensive, I think it's also probably not correct either.
Yeah.
Yeah. So would you say 5,000 dirhams is too much for an exosome, a proper exosome treatment?
A little bit too much, yeah.
Can I ask how much do you charge for exosome?
So it depends on how many vials.
Let's say 1 vial.
So it's around 3,000.
Okay, and one vial will do the whole face.
It's the whole face. Even some will be left for, like, I don't know, scalp or something.
Okay,
but that, don't forget, that includes the sterile needle, the dermapen, the actual numbing cream.
And you doing it.
Numbing cream, the time, and the exosome bottle. So I think around 3K-ish, plus minus, depends on the vial.
The size of the vial or the type of exosome?
Type of exosome vial, they're approximately priced, if they are done at the high level,
right,
they're priced approximately the same.
Right, okay, fine.
So, but clinic decides to charge maybe 5K. I would say it's a little bit expensive for that. But
because you have to have more than one, so how many are we talking? Depends on the problem, but
research, what I found, between 3 to 6 sessions.
Okay.
So 6 sessions give you most benefit, but then beyond 6 sessions, there is not a huge, massive benefit.
And over what period of time?
Between 2 to 4 weeks.
Each session. And then do you have to repeat it after 2 or 3 years to maintain whatever glow?
You do have to maintain. And sometimes doing exosome sessions every 6 months, possibly a good idea. But again, there is no long-term studies at the moment.
Right. So do 3 every 3 sessions. Once you've done 6, do 3 every 6 months. I mean, that's extreme. That's going to cost
a lot of money.
So it has to. We have to be able to show that the effects of it are worth that type of money, and then you can't get that from anything else.
Well, I suppose there are many other methods, isn't it? So
for
lasers,
collagen, I mean CO2,
lasers,
whatever.
CO2, yeah. But the downtime, people don't want to have downtime.
No.
Yeah, with the CO2, 1 week, you red face, right? 1 week
for CO2.
Yeah.
Oh, it could be a little longer than that.
5 days to 2 weeks, right?
I'd say, it depends how strong you go.
Yeah, so exosome, you came, tomorrow you great again.
And you're fine to go.
Yeah, you have no problems.
Okay.
So it's all down to convenience and downtime. Like if you kind of high profile person, you can't be out of action for 2 weeks, right?
Well, you can be. Depends how high profile you are, I guess.
Yeah.
But so because there's so many injectables on the market, like there's polynucleotides, there's all the different hyaluronic, Sculptra, Radius, and all these things that are meant to kind of almost do the same thing, like increase collagen elastin, make your skin look more glowy, blah, 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 blah. So of all the things that we know are out there, do you think exosomes would be the best thing to do if you want increased collagen elastin, or do you think it's kind of midway along the...
At the moment, it's not positioned anywhere, exosomes.
Oh, right, okay.
I wouldn't be able to claim it's the best or it's not, but I think it's a future.
Okay.
Once we get more data, we get the correct concentration, we get the right way of cleaning the exosomes, because the extra little particles which not exosomes create this scarring when they inject it.
Right.
So if they're not clean.
Oh, God.
So I think once we create the clean, reliable ways, of purifying exosomes, screening donors. Like if it's human donor.
Oh my God.
Yeah.
It's like blood donation.
Yeah. So it's a biological fluid, right? In a way.
Yeah, it is. Yeah.
So then we will possibly move on. And I think it will be quite fast. People working really hard on it. And every month or so, something new coming out.
There's a lot of money
about exosomes.
A lot of money to be made.
But I feel it's a future. We will be treating leg ulcers on nano level very soon. At some point.
Amazing.
And now they're investigating exosomes in actually treating cancer. So these exosomes, instead of giving chemo through the vein, they give exosomes, they deliver chemo to the cancer cell.
Right.
So new studies coming, I think it will be future, but we just have to wait and see. Yeah.
So what do you think about polynucleotides? Because it just showed up on the market recently as well, though it's been around for decades, but as far as I can see, 2 decades, 3 decades.
So there are some studies actually showing that pre-facelift and post-facelift, the injections of the Italian brand.
The Italian brand.
Yeah.
Only the Italian brand.
Yeah. So they've been over 15 years on the market. So it shows actually some benefits. But again, it's a kind of, we recently start using it a lot.
Yeah, like a lot.
Yes. And now my tutor at Masters, he's actually really having really good results. But again, the thing, it has to be administered properly.
Yeah.
By a proper brand.
Made by a proper
proper
brand.
person,
Proper person.
trained person.
Yeah.
And it has to be done in a way for the right patient.
Yeah, of course. Yeah.
So obviously, if you just walk in and I want polynucleotides, you won't get the results.
It doesn't mean, I mean, that's, yeah, I mean, an aesthetic oculoplastic surgeon who trained with Daniel Ezra, you know, Daniel Ezra, the oculoplastics guy.
In London?
In London.
Possibly, yeah.
Mr. Ezra, yeah, he's like,
I think,
yeah.
I
He does
heard,
he does the Ezra Fellowship for aesthetic oculoplastics. So there's one person who's trained there with him, and her name's Alia Isa, and she works at Moorfields in Healthcare City.
Okay.
So she's also my ophthalmologist. So, but she has this special, this super specialized training in this very niche field by the top guy in Europe or even globally, Mr. Ezra, who's really famous and does beautiful work. But anyway, so she was telling me how they've started using a specific brand of polynucleotides. I can't recall what it was. I'm not going to name it. Specific brand of polynucleotides to treat dark under eye circles, which is like one of the biggest problems that so many patients have. They found, and this is all preliminary data, and she happened to tell me, she doesn't mind, they found that they can improve the appearance of dark under eye circles in darker skinned people, so not Caucasians necessarily. And she uses a flexi cannula. Yeah, they go in from here. And it's
like a filler,
like a filler, and they like do a fan type pattern into the under the eye.
Yes.
And she's finding that very promising. The Ezra and his oculoplastic people are finding that as a promising way to treat under eye circles. And so that's the only thing I've seen about polynucleotides that make it perhaps helpful.
I was trained with this technique in my master's, by this tutor. I had it done to myself. And I find, personally, I liked it on myself.
On your under eyes?
Yeah, 3 times.
3 times? What do you think it did to your under eyes?
I was very hollow and very black.
Okay.
Here, vascular.
Yeah.
And I feel better.
Okay, improve the appearance.
Physically, appearance-wise, I felt it benefited me.
Right, interesting.
So, and we were trained in this cannula technique.
Yeah.
Rather than papules.
Oh God, yeah. I mean, I've done that a couple of times, people, and I'm like, oh, I can't do this anymore. So I'm now using the flexi cannula. Yeah.
So, and I think it's, again, we just have to wait and see how it works.
But is it harmful?
Harmful?
I don't think so.
I don't think
so. I feel like it's harmful.
Exosomes, from my research, there was no any adverse side effect apart from if they're being injected.
And that's the granuloma issue.
Yes.
Because you're going too deep.
But they're not harmful.
They're harmful.
It's not only because of too deep, because they're not fully purified.
Oh God, here's where the brand comes into play.
Yeah, so those kind of things. What do you think about threads?
Lifting. I mean, I've looked into this extensively because I was like, should I be doing this? And I wouldn't suggest it. I have seen a lot of complications, more than I would like to see, from people who had threads done.
Yeah.
I know, I mean, like holes in the skin, they can see the wire, like things like that. I think it gives a very minimal lift, like perhaps a couple millimeters if it does it all, and it's very temporary.
Very temporary, yeah.
Like super mega temporary. Like I looked at a study that looked at threads for brow lifts.
Yes.
And it was like it was a 1.5 or 2 millimeter increase in brow height, and it lasted for 3 months.
Yeah.
I mean, the pain of
it's not worth it.
It's just not worth it. It's relatively unsafe to do, I think, because the risks are quite high with the puncture in the skin. It has to be sterile,
right?
And also has to be sterile. But like, I've never done it. Have you ever done it to someone? Because I've never done it.
No, I didn't want to learn.
Yeah, I didn't want to learn it. In my master's, I didn't want to learn either. I was like, no, thank you. Because I just felt it was just too barbaric.
We actually were not taught threads.
Yeah.
My sort of tutors, they didn't do.
Mine was run by plastic surgeons, so in Queen Mary. So we did learn all about them. But I was like, this sounds like a bad idea. I mean, what do you think? Kind of the same.
I remember when I was working in London when I did the shift. The lady came 10 years ago. She had done threads.
Oh God.
And she formed granulomas.
Yes, I've seen that happen. Yep.
And we did biopsy. It was sarcoid.
Oh my God.
So she developed sarcoid.
Sarcoid granulomas.
Yeah.
Are you sure that connected? So what is sarcoid? That's a granuloma disease that can happen anywhere in your body.
So basically autoimmune response. And we don't know the cause for it.
We don't know the cause.
But histologically they have distinct granulomas.
Appearances.
So basically the sarcoidal granulomas formed on the 10 years ago thread which was inserted into her face.
You could still see the thread?
Yeah, she had beads of this where the threads were. She had beads of granulomas.
She could feel them, I imagine.
You can feel them, could see them.
You can see them. So how do you treat that? You can't treat
can't
that.
treat it much.
It cut them out.
Will disfigure her more.
Oh yeah, I've seen that with sculpture and radius.
I treat those when they're fresh. You can do well after
If
3
they're
months,
older,
3 to 4 months.
trouble.
If they're like years old, then you're really stuck.
I had to cut a few out of someone's mouth because they were here.
Yeah.
And so I did it intraorally to remove them because obviously I have to cut all around here. So she wanted some of this patient of mine. This was one time I did that. And I was like, this is brutal, which is why I have never done sculpture or radius. Well, no, I'm doing a little bit of it now, but not to the face.
I don't do it at all.
You don't do it at all?
I'm just waiting and seeing if any better products will come out.
Yeah, so I'm doing something with hyper-dilute radius for abdominal crepey skin. I'm just trying it out.
Abdominal is okay, I suppose.
You're not gonna if you get granulomas in your abdomen, it doesn't matter. But
okay.
it's super diluted, so then hopefully that kind of calcium ball won't become a granulomatous type of permanent thing. But the whole, I mean, I've done a post about this recently. The whole concept of it sounds very hocus pocus to me, but people love it, and like plastic surgeons hate it because it messes up with their facelifts, apparently, from what I understand.
Depends on a plastic surgeon. Some of them don't mind, some really mind.
Yeah, some of them on Instagram, they really mind. But then some, a lot of dermatologists and cosmetic doctors, whatever, they totally think it's fabulous. So
those who think they're fabulous, they don't see complications. They say, I've never seen a complication.
Yeah, that's
because
not true.
Because they land in my clinic or your clinic.
Yeah, they don't go. That's the thing. If someone has a complication from an aesthetic treatment, they don't go back to the original doctor.
They don't.
They end up going to you or me or someone else to kind of
else.
fix the problem.
Yeah.
So that these doctors never know they made a mistake.
Yes.
I always hope if I ever made an error did something bad to someone with an aesthetic treatment, they would come back and I could fix it.
No, it's all about trust.
It's all about trust.
Yeah.
So, you can really...
It would be nice to see the patient, like in UK where I like, because you see them again.
Yeah.
And you possibly go to Royal Society of Medicine. They recently presented granulomas after lemon bottle injection.
After what bottle?
Lemon bottle, the dissolving... the dissolving extra fat, lemon bottle.
It's called lemon bottle to dissolve it, and they inject it into the fat?
Yeah.
Like Kybella kind of thing?
Kind of, yeah.
Oh.
So they presented. So when you go to Royal Society of the meetings once a month, and you remember, you will see they actually present complex cases. This is 2 years down the line. We've tried 5 treatments and the patient did it. And then eventually they figure out what's wrong, right? But the beauty of that patient actually goes to the same team of doctors
over years.
in the same hospital. Eventually they figure out because there are difficult conditions, which is not like they don't read the books.
That's why you need more than one dermatologist sometimes.
That's the reason we need the MDT and clinical pathological.
So we don't get into this problem. But no, that's super interesting because it's interesting that you don't do sculpture radius either because I'm
waiting to see better product.
Yes, I'm waiting to see better product. Yeah, I'm waiting to see better product too. But I just, I won't do something to someone if I'm not sure it's going to give them a really positive result.
I wouldn't do it to myself, so I don't want to do it to anybody else at the moment. So I would just leave it to see. If I do it to myself, most of the treatments I do, I try it myself.
Yeah, me too.
Yeah. So if I liked it, if it worked for me, I will offer. If I didn't like it, or I'm not sure about the quality, I wouldn't do it to myself. I wouldn't offer.
Yeah, but also, so I would only try something on myself that had some type of scientific backup to show that it's... No, of
course, before you choose the treatment, you investigate and then you try it. Yeah. But obviously in aesthetics, the pyramid of the evidence, right?
Yeah.
So the meta-analysis, RCT is at top, and we are actually in aesthetics at the case reports.
Only.
We are still key opinion leaders in aesthetics. The very low, no evidence.
Oh, yeah. Yes.
Base.
Yeah.
Key opinion leader goes there, presents this, key opinion leader goes there. Instead of saying we've done RCT and he presents RCT like in psoriasis, eczema.
Yeah.
Nothing.
No, there's none of that.
So key opinion leaders still in aesthetic medicine.
But the key opinion leaders are chosen by by Restylane and Juvederm to be the key KOLs.
It's basically an anecdote. So they come and tell you, I believe, you have to trust me. Why? Where is your backing? Where is your research?
Yeah, that's a crap way to do things. Have you done Profilo to yourself?
Profilo is just hydration.
Yeah, I know.
It's lasts for a couple of days, weeks, depends on the person, and it's only temporary, like drinking water enough or hydration. It's meant to do that. Yeah. It's if you're happy to use it, that's fine. People like it. It plumps collagen, but you have to have collagen to plump it.
Yeah. It doesn't work for everyone.
It has to work in combination with something else.
Yeah, and I find that doesn't help younger people. It doesn't do anything.
Yeah, because
for
you have collagen.
You have enough collagen
to plump it.
Yeah. So, it's a bit weird. But yeah, I tried it twice. I didn't see any improvement in my skin. I tried it when I was like 36 because it had just come out on the market, and I bought myself a couple of boxes to give it a whirl. I didn't think it didn't really do much to me. So I'm very reluctant for patients to do it, to have me do it to patients. It's quite expensive for what it is. I don't think it's really worth doing. So
the Profilo is just a brand, but they have lots of other,
there's also other
other similar things.
But it's marketed as a bioremodeler. That's literally the term used on the marketing. And that doesn't mean, what does that mean? No idea.
I mean, it's just hyaluronic acid to hydrate. It doesn't remodel.
Yeah, but then
anything.
it would be like a skin booster. And then that's totally different market. Skin boosters are relatively cheap compared to Profilo. So,
well, maybe Profilo because of the brand is like a Louis Vuitton or Hermes.
I don't want to pay for the Louis Vuitton hyaluronic. I just want the regular one. So I'll take the Michael Kors version of that one. So
what about lots of people talking about Ozempic face?
Okay. Like the
slimming,
face.
Yeah.
I mean, I think when anyone loses face fast, and I've done a lot of fast weight loss in the past few years, you will get that kind of, gaunt appearance.
Yeah.
And it starts in your face. For women, it's face and boobs. That's the first place you lose body fat when you cut down. I mean, I go through phases where I go from like 190 pounds to 140 pounds in the span of like 5 months. And I get Ozempic face. I'm Ozempic face. People always say to me, like when I'm close to getting to my stage weight, they're like, yeah, you look really sick. I'm like, yes, that means I'm lean enough. And that is Ozempic face, looking sick, gaunt.
You're very lean, no extra fat.
No extra fat. And you can see it's really quite scary. You can see all my bones and you can see that. And I think that's just that happens when you lose weight relatively fast or even slowly. You'll eventually, if you lose a lot of body fat, you'll lose the fat in your face, and that's normal. So I think the Ozempic face is pretty funny. It's almost like a way that the media can differentiate between, like, they say, this celebrity has Ozempic face, they lost all this weight because of Ozempic. I don't think there's anything bad about that. Like, if you have a weight problem, these drugs do really work, and they're relatively safe from what we can see.
Yeah.
So, but if you need to lose 5 pounds, then you should probably not need Ozempic.
Not need Ozempic. Yeah. Ozempic is a drug, and drug has indication. And every medication, including paracetamol, has side effects.
Paracetamol, lots of side effects.
So when I say people, you can get liver failure from paracetamol, they're like, we never knew.
You never knew. That's why it's sold in packs of 16.
Yes.
You take more than 16, you might die.
Yeah.
Literally.
Exactly.
Yeah.
So when they say, what is the best, safest treatment? Every medication has side effects. Every single medication. But it depends if the benefits outweigh the side effects.
And we have to make that decision for the patient.
Yeah.
That's like our job. But what do you think of Ozempic face?
I don't think anything about it.
Okay.
I think if this medication is required for diabetes, for obesity, and it's prescribed by a professional for correct reasons, I think if you have that side effect, but it cured your obesity, hypertension, risk of stroke, risk of heart attack, diabetes under control, then doesn't matter what face you have. You have life back.
You have life.
But if you're only taking because you're lazy to go to the gym, it's your decision, right?
Yeah, it's your decision.
So then you just deal with it.
Yes, but you always have to think, if you're over a certain age, if you start losing a lot of body fat, you will have to choose between your face and your body after a certain age. That depends on the person. So right now I'm able to maintain a roughly normal facial appearance, even with weight loss, but I know there will be a point where that's not going to happen. But I do have to go get my face tweaked with Dr. Claudia Machado, the plastic surgeon. And I'll let you, why don't you do it next time then?
We need to ask her to come.
Ask her to come. So she takes Profilo actually, and she like puts it just all over the place to give me like a 1 month kind of temporary kind of balancing, so I don't look so gaunt on stage, because it looked really bad on the with the stage lights and the photographs. And that it works beautifully, but it's very subtle, and then it just goes by the time I'm back from it.
But then you put your weight back on.
Yeah,
you
exactly.
Get your face back.
And I get my face back.
Then you don't have overfilled
and more of a face.
Don't get overfilled. We haven't talked about so many things.
Yeah, I know.
God.
We need to.
It's too much.
We actually haven't talked about anything I meant to talk about.
Yeah, but anyway, we have to book it again.
Yeah, but
I want.
Yes.
To ask you, just my last question before I have to wrap up.
Yeah.
What inspired you?
Oh, to write this book. It was it was inspired by Instagram.
positive things come out of
positive things of the book, but not Instagram. Yes. Oh, yes. The book came out of Instagram, but that's inspired me in the sense that I was seeing so much complete nonsense being spewed all around Instagram about skin and dermatology and everything, skincare. And I was like, and I got so many people asking me the same question over and over again that I just compiled all the questions and just based the book on the Instagram questions.
Okay.
So I try to structure it around what people were actually asking me, like about acne and then acne treatments, Accutane, So it's all the most common questions I was getting through Instagram.
Yeah.
Because I do a lot. I used to do more, but I used to do a lot of like weekly lives and things like that.
Yeah.
So I'd see all the questions.
Yeah.
And every week it was the same thing.
Same question again and again.
Again and again. So I was like, I need to write a book about this so people can just read the book and not ask me the question. People still ask me all the questions, but at least I can say, please read chapter this in the book.
So I heard about fear of missing out on skincare.
FOMOS.
Skincare.
Yeah, FOMOS. Yeah, I invented that really cool phrase.
Yeah. So it is actually big thing at the moment. I see a lot of perioral dermatitis, a lot of dermatitis actually. After people use acids, vitamin C, retinoid, then they wash with some peroxide, and then they do hydrofacial, and then they scrub with that, and then they come, oh, doctor, what's happened? I'm using this beautiful skincare routine. From
the most expensive skincare company in the world. How can this be possible? Like,
yes.
Oh, God, here we go.
It's overused.
It's overused. I see tons of PD now from overused skincare.
Yes.
And the patients never understand. So the first step I do is I say, stop everything you're using.
And so like, oh,
yeah, I can't stop everything.
So much.
Even sunscreen. I'm like, okay, well, yeah, even sunscreen actually, because sunscreen can be piled on with everything else and cause problems. So I'm like, actually, for the next few days, I need you to stay out of the sun and wear a hat or whatever, because you're not going to die from not using sunscreen for 3 or 4 days. But if you do that, it'll definitely help resolve the skin problem. So I'm like, stop everything, put it all in a box, hide it away permanently, give it to a friend you don't like, whatever. And,
overuse of skincare. It's like an epidemic, like a COVID wave.
Yes, it's like there's a COVID, an epidemic of overuse of skincare. 100%. Yeah, 100%.
And kids from age of 9 is just disaster.
Yeah, I know, it's a disaster. It's terrible.
I think that should really stop. Parents, it should stop.
Because I see a lot of like acneiform eruptions in like 9-year-olds, 10-year-olds. And I'm like, well, is this acne or is this something else that's happening here? So obviously we can tell the difference between acneiform eruption and acne comedones and so on. So, but how much of that is actually, are they able? I mean, I don't think that skincare can necessarily cause acne generally, but you can definitely irritate. If you have a little bit of acne even, it can almost certainly irritate enough to make it a problem. So I'm definitely seeing a lot of 9, 10, 11-year-olds, females mainly, with pretty bad acne, which back 20 years ago, I don't think we saw that.
Well, I don't think kids started using skincare until 15, 16, 17.
Yeah.
Now we're seeing 8, 9, 10-year-old having full on.
They buy their own derma rollers. Derma roll their serum into it from The Ordinary.
No good.
So no good. I mean, it's just terrible. So I mean, I don't know we can't really stop that. Every time I see a teenager like that and I'm like, or young, not even teenager, can you stop using all these skincare? But no, everyone else at school uses it. And I just
psychologist.
Send them all to a psychologist. Send them all to a psychologist. Oh my goodness. Yeah. We need to find like 20 psychologists who just deal with that.
Yeah.
Yeah. It's just terrible, I think. Because you have a daughter.
Son.
Oh, just kidding. Son. But he's not old enough to like skincare.
No, he's okay. He's okay with moisturizer. Okay. Just one simple basic moisturizer.
And a bit of sunscreen slapped on.
Sunscreen, of course, yeah.
Yeah, he's just pale, yeah.
That's it.
So it's a huge
We
topic,
haven't covered lots of things.
No, I know.
Which we actually wanted to cover papers. We need a journal club meeting.
We need a journal club meeting. So,
about the safety of sunscreens, about the food and eczema.
Food and acne. What a topic. Yeah. So we'll have to cover all those another time. Yeah, next time. So cool.
But you will sign it for me, right?
Oh, yeah.
Thank you so much.
Absolutely. I'll sign it for you.
Use advantage.
Yes, always fun. I will sign it, and then you have to read it.
Oh, yes. Yes.
This is a special copy for you.
Yeah, you see.
You can read it, and what you'll do is you'll highlight things that you think are incorrect.
Okay.
You can do that, and we can discuss that.
Okay.
Because this book was written in 2022, so it might be, lacking.
We need a volume 2 then.
Yeah, well, in
New
addition
trends
to,
emerging. Look,
I think I'd have to wait another 4 years, I think, or 3 years before it needs a second edition because of new stuff.
yeah,
Yeah, it's going to happen though.
will be exosomes in there.
Yeah, but I'll just put your paper in there.
But I think exosomes overtook the session today.
Yeah, but it's, you know what, it's a topic I don't really understand until you explain it to me, because I'm also confused. When I look at the papers and I look at the studies, it's just a lot of work to go through everything and to pick out the 19 ones that are legit.
My head nearly exploded when I was doing it.
Well, yeah, I can imagine. So
It was just like, poof. Thank you so much.
yeah, I mean,
thank you so much.
So we work full time. So for me to go home and in my free time do a systematic review of the exosomes, like I need someone like you who has done it for a master's
Yes.
to then give me that information, because otherwise, you know, I'm not going to find it on my own.
Hopefully, I get some presentation in AADV. I submitted my abstract as well.
The EADV
Yeah.
for October.
Yeah.
Oh yeah.
So fingers crossed.
Fingers crossed. I'm sure they'll accept it.
Fingers crossed.
Yeah. All right. Great. Well, this was fun.
Nice to see you. Thank you so much.
Good conversation. Yeah. Thank you too. All right.